Hello, everybody. This is a quick rundown of perhaps how to prepare for the assembly. So let's have a quick look. What you see on the screen here is our phase one ICER template, but it's actually combining two articles because one, they're both related to each other but from the same study, just an extra analysis. So we thought we would do them side by side. So, but what I want to show you is that, so that's why ours looks very messy and dense. But what I did do to prepare for the assembly was I made at the very bottom, I made a little table of what to say, what I wanted to speak about. And I'm going to try to do this in, well, we're doing one article, we're trying to stay within 5 minutes. But mine will probably go over a little bit more because of the extra study that I'm trying to combine with this one. And I think actually in the assembly, I'm going to be doing 4 at once because they're all 4 of them related to each other with the same exercise program. So basically, sorry, back and forth. I didn't mean to do that. But so what I did is I cut and paste just from my group's template up here. And the easy way to do that is by going into view. If you wanted to do that, for example, by going into view and then go to split screen, and then you put the split screen here, and then, so for example, I had my boop, boop, boop. On the bottom, I put my my preparation for the assembly right here, and on the top screen, I just scroll through and cut and paste from my group's phase one survey, which again was a combination of the two, and then I just cut and paste and put it in, and I scroll down for anything. And so there's a place for the article talking about the design here. Notice the 2 articles, article on the left, article on the right. I think this one is from 2002, if I'm not mistaken. But you just have to put the title, really. The dates are fine. And the design, and then the patient population. So we're just extracting the most important objects here. Medicines, how they handle the medicines, basically, and the exercise program. And then here we will list the we're going to combine the outcomes with the disease profile, because a lot of the disease profile variables are actually outcomes. So you'll see, and then so we talk about at the same time we're talking about the outcome measure, we're also talking about the results of the outcome measure, how it performed, and then we talk about safety and the feasibility we added to it because it's important for the patients in terms of the exercise program. Then a little summary. And then you don't have to do this, but it's just good to remember that if we feel like we have incomplete data, we're going to go and ask the authors. Yes, we still have information we want to ask of the authors. And then we have a bunch of recommendations that we feel might be important considerations when developing guidelines, and considering what outcome measures, and considering trial design, and what we'd hope to see, and also so that would address reducing bias as well as feasibility for patients, etc. So, okay, so now what I'll do is I'll just try to go through my 5-minute thumbnail. So You could see how you do. And again, the purpose of all of this is to discuss what you've come across, get as a group and as individuals more and more familiar with these concepts, and just to talk about it more, hear about it, cultivate a sensitivity to the important elements of trial design, because we're going to go on now after phase 1 and phase 2 and develop guidelines, and that's going to be informed on how we've cultivated our experience of these articles, and becoming more thinking. We're helping each other, and we're becoming more entrenched in the thinking of this. Yes, so yes, so I would start off by saying the title of our article is Safety of a Home-Based Exercise Program in Patients with Polymyositis and Dermatomyositis, 1999. There was also a 2002 study which rode on this study. It was the same patients, and basically what they did is they looked at muscle biopsies. So I'll talk about both of these in tandem. The main study was an open design proof of concept observational, whereby the assessor, the physical therapy assessor, was not blinded. The tandem study was evaluating muscle biopsies before and after. This one actually happened to have a healthy control group. And here the pathologist was blinded and the specimens were shuffled, randomly shuffled. So going back to the patients, in the original study, these are patients, adult PMDM patients. There were 10 completers, 8 female, 2 male, 5 DM, 5 PM. They met Boehm and Peter criteria. IBM was actively excluded, and patients were verified with a biopsy. These patients had inactive or stable disease as verified by MRI or biopsy, but they had residual muscle weakness. You can see that I feel like I'm missing some information here. I flagged that for myself. Maybe I'll have it in time for the assembly, maybe not. The median age was 53. And what we did have about these patients also was an activity profile before they started. So we knew how many times a week people exercised. We also knew what their work situation was, which was good because it helps inform functional status, as well as potential for compliance, because maybe they're too busy. But there was no other information like smoking, diet, socioeconomic status, education, etc. The medications were captured in pretty much name only. Glucocorticoids were captured, but not individual or group doses for this study. But it was the group dose for the glucocorticoids was indeed reported for the muscle biopsies evaluation study. So I guess they had a little bit more room, so they added that in there. And we actually got a lot more information about this study from this subsequent analysis study. It's always about word count in publications. So the exercise intervention, it was a land-based, home-based, standardized program for aerobic and resistance exercise. 15 minutes daily, 5 days a week. In addition to those 15 minutes for 5 days a week, there's also walking for 15 minutes at a self-selected speed for, again, 5 days a week. So the exercise program itself consisted of a warm-up, which was separate. There was a climbing up and down of a stool. There was a pulley apparatus whereby patients gripped and strengthened, used a grip pulley, strengthened their grip, upper arm and shoulder. There were quadriceps hip muscle strengthening exercises, about 10 repetitions, sit-ups without support of neck, and careful stretching. And this was not specified. The intensity was defined as 50% of the voluntary maximum repletion as unsupervised. For those with patients with moderate reductions, meaning a little bit more, they had an additional weightlifting experience with additional weights, 0.25 to 2 kilograms for upper limb strengthening, and that was included. Additionally, very important, the support that these patients received were initial instructions with actual training, and then written and taped instructions. And then there were weekly check-ins with the physiotherapist on the phone, and they kept a diary for compliance reasons and I guess for other reasons at 12 weeks. The outcomes that the IMACS tools were not used because they were not available at this time. Um, and The functional index was used to test muscle endurance. The MMT8 was not used here, and the FI had statistically significant improvement in the group before and after. Um, and this was in the total score and in the upper and lower extremity scores, but there was no difference in the neck, trunk, and peak expiratory flow. And this is an important consideration. We felt, and individually, before and after 6 individuals had statistically significant improvement, and the remaining 4 less than a 20% reduction. But no patients had any decline in function, and that was super important. And one patient lost a point in their hand testing because of a flare. So that's really important, we thought later on to consider. The other examination was walking distance on a treadmill for 7 minutes, and that also was statistically significant pre and post. The SF36, that also had statistically significant changes in physical function and row physical. I did look up that there should be about 5 points for each scale for MCID. We did have additional questions for the author because it appeared that that was met on some of the other scales. The pain VAS didn't seem to show any difference, nor did the muscle weakness VAS. The disease impact score also, it's a 0 to 5 Likert scale. The ESR and CRP were inflammatory markers. There were normal before and normal after, I believe, and the CPK was checked before and after, but this was for safety mostly. Again, well, before we go on to safety, let's talk about this study on the right. So what they did here was they looked at serial muscle biopsies, and they additionally stained them. They verified that the muscle biopsies before and after had posse inflammation, and in fact, the ones that had a little bit of inflammation actually improved without inflammation in the exercise after exercise. The muscle biopsy was gotten one side before, one side after, so that there was no artifact involved. And then, in addition to staining for inflammatory infiltrates and other grosser findings, these were stained for ATPase staining to demonstrate the proportion of type 1, type 2C, and type 2B fibers. And type 1 fibers are slow twitch fibers, and those reflect endurance. And predominantly compared to controls, in healthy controls, the patients with myositis had significantly decreased proportion of type 1 fibers. After exercise, these increased dramatically, and the type 2C fibers, which are fibers that could actually differentiate, it seems, to either slow or fast twitch, ended up apparently they were lower. So the theory is that they ended up becoming the larger bulk of what we saw in the type 1 fibers, meaning that there's more fibers that support endurance because they have more mitochondria. So that was a beautiful finding. And also the denseness was of the muscle fiber, and muscle fiber area was looked at, and all of these correlated with the findings of the functional index. So that was really brilliant. So in terms of safety, the muscle biopsy was used for safety as well, to make sure that there was no changes in the muscle afterwards, and inflammation. There was no increase in inflammation, and in fact, actually, there was a decrease in inflammation in those biopsies. Also, MRI was looked at, and um, CPK, to make sure that there was in fact no damage happening to the muscles, causing more CPK elevation. So the feasibility, patient research partners agreed that it seemed feasible and sustainable for someone that does not have active myositis. 15 minutes walking was also doable. And they felt that the 15 minutes for either walking or the actual exercise was too much for people with active disease. Just projecting, this was, and again, a reminder, this study was for inactive, stable disease. There was some concern about adherence. They thought it was cost effective and that it was at home made it very convenient. There was some questions about the equipment feasibility and was there enough space at home. But in summary, they felt that this study, though it was not a randomized controlled trial, they felt very confident about the results. Although there was a low number of patients, there was multiple methods of examining and multiple levels of examining impact of exercise, including muscle biopsy changes. And these were very consistent and correlated with each other. We did have further information to request from the authors. There were some information that we felt were content that was important to bring forward. We felt IBM always important to address isolated in some manner. I think now we would use the ICER criteria for diagnosis as well. One of the things that we've noticed is that 2 people dropped out or 3 people dropped out because of infection, influenza, and bronchitis. And that was a large number of the patients. 3 patients are a large number of patients. So thinking ahead, how could this be handled for future studies to prevent dropout? Baseline activity profile was a very important thing to capture, and we noticed is not captured in all studies. And this could actually have a lot to do with adherence to program. Also, the work status we were impressed was what was captured. There was no discussion of ethnicity, nor race, nor smoking, nor education level, or diet. We thought that was important. And should there have been a primary or co-primary assignment, even though this is an observational study, is a question. The group thought it was important that the entire exercise program for any exercise study done in myositis, that the regimen appears either in a table or in a supplement, and if that's part of our guidelines, then the publishers will have to accommodate for this, and that would include how intensity was accelerated, the decision-making tree for that, as well as if there's stretching, how that was handled and how that was, and what stretches were done. The group also felt that design and publication in serial muscle, should address whether the subjects were limited to the said exercise, or were they allowed to do other exercise. And then we would encourage sutureless biopsy, serial muscle biopsy for future investigation of different types of exercise studies. And the question we had was MMT8. Is it needed to supplement FI and FI2 in these studies? And we thought it was important that one patient lost points in her hands for flaring, and that arthritis is a very common experience. So how can we address this, or is this something that we should be addressing? Maybe we can discuss that. The other thing was that this exercise program did not show truncal improvement, statistically significant anyway, so there was no neck flexure or thorax improvement, nor peak expiratory flow, which was perhaps a reflection of accessory muscles of the chest. And so then our suggestion would be to examine what can be done in this regimen to address such. So yes, so that's it. And I will be sending this to you, and thank you so much for, I hope this helped, and take care. Bye.